This Power Series lecture, we're going to go over the femoral neck fractures. These fractures are intracapsular, which means the healing potential for these fractures is very limited, which if these are not fixed properly can lead to osteonecrosis of the femoral head. The osseous anatomy of the femoral neck can be broken down into three anatomical regions: the subcapital, transcervical, and basicervical regions. These are important because this helps to dictate different treatment options based on where the fracture is located. The neck to shaft angle is around 130 degrees and it's anteverted about 10 degrees. Do you know what the major blood supply for the femoral head is? It's the medial femoral circumflex artery. That is a very high yield point and will be asked about on every single rotation you go on, I guarantee it. And know what the calcar is. It's the posterior medial dense plate of bone. The classification for femoral neck fractures is very high yield. Do you happen to know what it is? It's the Garden classification. This classification is so high yield because we actually use it quite often in practice. Know that type 1 and type 2 are going to be your non-displaced fractures, and type 3 and type 4 are going to be your displaced fractures. This classification is so high yield because it's so simple, yet it helps to dictate treatment. So type 1 is going to be valgus impacted, type 2 is going to be a complete fracture but non-displaced. Type 3 is going to be a complete fracture, partially displaced, and type 4 is going to be a complete fracture and fully displaced. So type 1 and 2 can be fixed with screws or a sliding hip screw. Type 3 and type 4 are displaced, so you have to replace it. Whether you do a hemi or a total is going to come down to patient factors as well as surgeon preference. Now there's another classification called the Powell's classification that you certainly have to know. This is based on the angle of the fracture. Type 1 is going to be less than 30 degrees, type 2 is 30 to 50, and type 3 is going to be greater than 50. Type 3 are associated with higher energy fractures, and these are considered unstable. So now what do you have to remember from this? That type 1 and 2 are going to be screws, type 3 and 4 are going to be displaced, so you have to replace. Typical presentation, so you got low energy in the elderly population, and these are usually associated with osteoporosis. If it's high energy, these are usually younger patients, and you'll see a vertical fracture pattern, so that Powell's angle is going to be a little bit higher. And if you have a femoral shaft fracture, know that there's an association with the femoral neck of 6 to 9%, and that you're going to have to look for it. Now you're going to have to treat that neck before the shaft. Physical examination, do your log rolls because it'll be painful, but the big thing that you should always look for, if it's a displaced fracture, that leg is going to be externally rotated and shortened. And remember that the mortality risk with these are very high. A risk at 1 year is 25 to 30%. And if they have CKD, the risk at 2 years is around 45%. So it's very important that we fix these. Now, going over treatment options again. Remember, type 1, type 2, 3 cannulated screws. Type 3, type 4, replace. Because if it's displaced, you gotta replace. So, percutaneous fixation with those 3 cannulated screws. We're going to be doing an inverted triangle of partially threaded cannulated screws. Remember the order of these. You want to start inferior, posterior, then anterior. Remember IPA, like the beer. You want to go inferior because you want to get that home run screw right against the calcar, the strongest posterior medial plate of bone. You also want to be at or above the lesser trochanter to avoid a stress riser. The threads must cross the fracture site to get compression, and the most cause of failure is a varus malreduction. A sliding hip screw, these are primarily used for those basicervical fractures and in vertical fractures in younger patients. Arthroplasty, hemi versus total. A hemi, you want to give these to more debilitated, less active patients or patients that are prone to dislocation like Parkinson's, alcoholics, and seizure disorder patients. Total hips will be in the more active patients, or if they've already had pre-existing acetabular disease or inflammatory arthritis. Remember, always ask about the functional and ambulatory status when talking to the patient. Alright, lastly, potential complications with femoral neck fracture, that osteonecrosis because the blood supply is limited and the healing potential is limited. So there's increased risk with initial displacement and non-anatomic reduction. Non-unions, varus malreductions, the treatment is a valgus intertrochanteric osteotomy or arthroplasty. In dislocation, remember that total hips have a 5 to 7 higher risk than hemi. All right, that was a lot, but I hope this helps. See you next time.